EU 代表講演といたしまして、2019年の欧州臨床使用学会会長で、肉腫などの希少がんを含む世界のがん医療の権威であるフランスレオンベラールセンター教授ジャン・イブ・ブレイ様にご講演いただきます。テーマはがん撲滅に向けたがん治療最前線2023です。ジャン・イブ・ブレイ様の講演は事前に収録した VTR 映像でご覧いただきます。同時通訳をいたしますので、皆様レシーバーをご利用ください。それではお願いいたします。
Good day. First, thank you very much for this invitation to speak on the World Cancer Eradication Summit. This is really a pleasure and an honor to be sharing with you some consideration on a quite original topic, I would say, which is the preventive immunotherapy of second cancer, which I would like to cover in the next 15 minutes. My name is Jean-Yves Blay. I'm a medical oncologist working in a comprehensive cancer center in Lyon, France. And these are my disclosures, both as researchers working mainly on targeted therapy, immunotherapy, and rare cancers, and as a director general of the hospital. Today, I would like to cover actually three different topics. First, the topic of immunotherapy in cancers, where we observed in the last 15 years a tremendous rate of progress of the use of immunotherapy in cancer towards the first line, including in adjuvant treatment. The second topic I would like to cover would be that of second primary cancer, which represents now a growing problem for a growing proportion of patients who are cured of their first cancer and who will not relapse, and where second cancer can represent a significant risk of death for the future for this cured patient. And then we will discuss the recent results exploring the analysis of a large data set of electronic health records and database, showing that we may have a new preventive strategy to prevent second cancers. And this is a topic for research that I'm going to discuss. Let's start first with the role of immunotherapy of cancer. We know that the immune response of the host against the cancer is something important to control the development of cancer. And one of the hallmarks of cancer, this is a classical series of papers published in the last 20 years, the latest being that presentation by Dr. Anand. We know that one of the key characteristics of the cancers, all cancers, is to avoid immune destruction. There are new dimensions in the hallmarks of cancer, which include epigenetic reprogramming, polymorphic microbiomes, senescent cells, tumor plasticities. All of these are also related to a capacity of the immune system to recognize, destroy, and control, in general, cancer cells. So the control of the cancer progression by the immune system is something which has long been identified as a key problem, and we know that from a vast, large data set which demonstrate this fact. So this integrates avoiding immune destruction in one of the key hallmarks of cancers. In parallel, and since more than now 15 years, we have seen the development and the approval of immune checkpoint blockers for a large number of disease types. And the number of immune checkpoint blockers, first anti-CTLA4, then anti-PD1, anti-PD-L1, anti-LAG3, and several others which are still under investigation. The growing number of indications and approval clearly shows what is happening and to which extent the development of immunotherapy of cancer has been changing dramatically the outcome of patients with cancer. One probably of the main characteristics of the recent years is our capacity to develop immunotherapy of cancer, not only in advanced phases, but also in early stages to prevent disease progression and actually to prevent disease relapse. And the use of PD-1 antibodies for prevention of relapse of tumors at high risk of relapse, such as stage 3 melanoma, has been one of the first examples to demonstrate that. We know that patients treated and receiving, in this case, pembrolizumab, had a better outcome, a better survival than patients not treated with pembrolizumab, in this case, treated with placebo. This is probably the case also for many other tumor types, including non-small cell lung cancer, where several studies have been demonstrating a reduction in the risk of relapse, or also with perioperative pembrolizumab in this case, again, in early stage non-small cell lung cancer, the capacity of the PD-1 group to improve the outcome and the survival, in this case, of patients in localized phase. So immunotherapy is useful in advanced phase, and actually it's probably going to bring most important benefits in patients treated in early phase, where it may prevent relapse and prevent the risk of death, which is emerging from relapse. Who are those patients responding to immunotherapies? That's something which is quite intriguing, and we've been exploring the predictive immune markers in a large variety of different tumor types with non-consistent biomarkers across tumor type. PD-L1 expression, the level of expression on tumor cells and infiltrating cells, the presence of immune infiltrates, presence of tertiary lymphoid structures, the nature of the mutation load in tumor types, aneuploidic tumor genetic makeup, which have all been identified in a wide variety of different studies to be predictive for the chances of obtaining a response and tumor control in patients with advanced cancer treated with immune checkpoint blockers. So we have a large data set, and probably we are not there yet. Other approaches to identify the different immune subset of cancers, which are probably shared across many cancers with a difference in the distribution of different immune subset of cancers, which is reflecting the intrinsic diversity of the cancers within a given cancer type and also across cancer types. Some tumor types may be more inflammatory and possibly more responding to immune checkpoint blockers in this category, but the point is that we do not have biomarkers which clearly demonstrate uniformly their capacity to identify patients who are going to benefit from this treatment. Probably one of the most interesting, however, biomarker, which also illustrates the value of treating patients in an early phase, has been the treatment of patients with PD-1 antibody, in this case pembrolizumab, in MSI-high tumor. And there have been several recent studies using pembrolizumab, which have been showing that in patients with advanced colorectal cancer and MSI-high, pembrolizumab is superior to chemotherapy for progression-free survival. Actually, treating patients with MSI-high, but also MMR proficient early stage colorectal cancer proved to be quite interesting. Again, early treatment of the disease may provide a completely different type of biological response in these patients. In this case, this was the first experience on patients with early stage colorectal cancer, regardless of their MSI stages. A very interesting niche 2 study reported last year at ESMO, showing the major pathological response observed in neoadjuvant treatment for localized CRC with MSI-high tumors. So that's probably another piece of evidence showing the importance of early treatment of patients with cancer with immunotherapy, if we can identify those patients who are the good candidates. So immunotherapy, maybe the earliest is the best, time will tell on other tumor types. The second topic I wanted to cover connected to that is the problem of second primary cancer. Since 10 to 15 years, there have been a growing number of publications showing the magnitude of the problem for adult cancer patients, survivors, cured patients, for younger patients, children, and young adults, where the incidence of second cancer represents a significant problem. Up to 18% of patients with cancers in these different retrospective series seem to have cancer which were second primary cancer. So we are facing here a growing problem, and this is something which needs to be addressed at a time where obviously we are curing more patients in the first with the first cancer, thanks to the progresses of precision medicine and several other type of strategies. But that's something which is a growing problem. We don't want our cured patients to be dying of a second cancer. So to explore this question, we took advantage of an analysis of the electronic health record of the hospital where I'm working, which gathers more than 300,000 electronic health records since '93. And we look at the incidence of second primary cancer over time in the last 3 decades. And what we observed was clearly an increase of the frequency of the problem, an earlier diagnosis of this problem, showing again that this is an issue which is increasing in incidence and which is becoming an important problem for these cured patients. Second primary cancer are of course clustered in different situations depending on the etiology of the first cancer. Tobacco, alcohol may be predicting for a typology of second cancer, which is different from that of genetic predisposition for breast or ovarian cancer, for instance. But nevertheless, there seems to be an increase in the risk of second cancer, regardless of the first cancer. And the age of occurrence of the second cancer is varying across tumor types, across gender as well. But that's something where probably we can conclude that the majority of second primary cancers come in the within the next 10 years following the diagnosis of a first and a primary cancer. So that probably tells us that there is heterogeneity here, and this heterogeneity needs to be studied further. When we are looking at this data set, actually, we explore the incidence of second cancer depending on the treatment. And we look at hormonal treatment, radiotherapy, cytotoxic chemotherapy, and immunotherapy. And the first report, actually, that we published in Annals of Oncology in a letter was the observation that patients with first cancer treated with immunotherapy, including immune checkpoint blockers, had a lower, red curve here, incidence of second primary cancer as compared to the other patients. To explore this in more details, looking in particular at the combination of the treatment, cytotoxics only, cytotoxics and immunotherapy only, neither of those, and we observed in all cases a reduction in the incidence of second cancers with cytotoxic only, but much more importantly, when the patient were exposed to immunotherapy for the first cancer. We look at that analysis in 2 different data sets. The first on the left-hand panel is a population of patients with metastatic and localized cancer. And we see that the green curve shows a massive reduction of the chances of achieving of not developing a second cancer following a treatment with immunotherapy in the first cancer. What is more important is on the right panel, where you see that no patients treated with immunotherapy in localized phase for the first cancer actually develop a second cancer in this data set. And the difference was, of course, highly significant. This was observed for all ages, as expected, young adults, children, intermediate age, and older patients. And this difference was significant all the time in favor of immunotherapy, significantly reducing the p-value is extremely low, significantly reducing the chances of developing a second cancer. Using a multivariate analysis, treatment with of the first primary cancer with immunotherapy was associated with a significant reduction of the risk of developing a second cancer. Okay, that was a nice study conducted on several thousands of patients in a single hospital. What about reproduction of this observation? We took advantage of a large data set which was collected in the Unicancer Federation, the Federation of French Cancer Center, on lung cancer. And we look at the same observation with a study population close to 10,000 this time, slightly less than the previous series, which was gathering close to 40,000 patients. A bit half of the patients were treated with immune checkpoint inhibitors first for their lung cancer, and some of these developed second primary cancer, and you can see the numbers. What is the typology of the second cancer? You can see here that the number of second cancers is actually quite different in the group of patients treated with immune checkpoint blockers for the lung cancer, but we can see all types of cancer, which are all for the incidence reduced. And this is exemplified on this survival curve, which you can see on the upper right panel, where you observe the incidence of developments of second primary cancer in the red curve on patients not treated with immunotherapy as compared to the blue curve treated with immunotherapy with a hazard ratio, as you can see, of 0.4. The lower curve shows the risk of second primary cancer and relapse of the first cancer, which was also significantly reduced by the treatment with immunotherapy. So we can see here in two different data sets gathering over 50,000 patients, two independent data sets, the treatment with immunotherapy for the first cancer is associated with a reduction in the chance of developing a second primary tumor. This is an indirect demonstration, and we need prospective validation of this observation to make sure that this is not a biased analysis. And for this, we have built a study which has just started a few months ago called PREDOSTAR, which is gathering adult patients treated with a curative treatment for a first primary cancer for any histologies with at least one risk factor for the second primary cancer, exposure to tobacco, genetic predisposition in particular, and of course, no contraindication to anti-PD-1 and no prior treatment with anti-PD-1. A PD-1 antibody, 4 courses of dostarlimab. B, no treatment. The statistical analysis will be conducted looking at the primary endpoint of the incidence of second cancer after 3 years with 2 strata, exogenous and endogenous risk to develop a second cancer. I will conclude there by saying that second primary cancer is a growing problem with more cure of the first cancer. Exploring large electronic health record dataset, we observe that this problem is increasing, but also that the risk to develop a second cancer is reduced by the exposure to treatment in the first cancer, in particular immunotherapy. There is a consistent decrease of the risk of second primary cancer after IO treatment for the first primary cancer, and we are investigating a new preventive strategy in a randomized clinical study called PREDOSTAR, and we are looking forward presenting these results in the World Cancer Eradication Summit in the years to come. Thank you very much for your attention.
ブレイ様のご講演でした。ありがとうございました。